So friends, we will now talk about prescribing low vision aids, right? So there are 4 very easy steps for prescribing low vision devices in our clinical practice. The first and most important step is to record vision. A lot has been spoken about that by my colleague Vivek. We'll discuss some more later on. The second step is to predict the magnification, decide what magnification a patient requires, and then you select a device for that patient and finally put him on training with that device. So these are the 4 simple steps. Let's discuss each one of them in details. Before I say anything else, let me tell you that this is the testing kit from Keeler which we use in our clinic, and the one on the left is for distance devices, telescopes, and the one on the right is near devices. But this is very expensive. We'd like to keep it simple. So what I'm going to tell you next in later slides will be how you can keep it very simple and do it on your own in your own clinic with the regularly available materials. So the first step, as I told you, was to find out and record the vision of the patient. So if you're using a regular Snell's chart, then for low vision patients, the optotypes have to be really huge like this for him to be able to see. But that is very impractical. So what you can do is actually have special testing charts meant to be used at smaller distances like 3 meters, or you can use a regular Snell's chart that is available in every clinic. Keep the patient, say 3 meters or maybe 2 meters or 5 feet away from the regular Snell's chart and record his vision. And that is a very practical thing to do in our daily clinical work. So we'll talk more about that a little later. But before that, let me tell you that this is the special chart available with the Keeler low vision kit. And this is used at 3 meters distance and it's got a predictive value. We won't go into all the details. This is the near vision chart which I have in my Keeler testing kit. This is the Bailey-Lowy chart which was actually made for low vision testing, and it has metamorphosed into the ETDR's chart later on. And this is again the Logmar chart meant for near vision testing, but we are not going to use it in our clinical practice. So let us stick to the Snell vision chart, and we record the distance on a regular Snell chart by keeping the patient at very close distance, say 5 feet or less than 5 feet or even 10 feet away from the Snell's chart. Once you record that vision, you have to convert it into regular test distance by multiplying the numerator and denominator by a suitable number. So if you see in this example, if you have the vision of 5/200, if you measure it in the American pattern, American system, then you multiply it by 4/4 to get a Snell equivalent of 20/800 visual acuity. Or if you're using the British nomenclature and you're testing at 3 meter distance, then a vision is 3/24. You convert it and you get 6/48 Snell acuity. So this is the way how we find out the vision of a low vision patient using this regular Snell's chart. Then here are the steps to prescribing distant low vision devices. The first and foremost thing is to give a proper spectacle correction, as Vivek has already mentioned. No, Dr. Ali mentioned that if you give spectacle correction to a patient, then it increases the sharpness of the retinal image and maybe improves his visual acuity by 1 or 2 lines. So that is very important. The second thing to remember is that if the patient has got good vision like 660 or even 560 and he's able to navigate in the environment on the streets in the home milieu, then there is no need for prescribing any distant vision aid. All right? The third thing to remember is that you have to prescribe a low vision device or telescope which is of the lowest useful power. Now there are 2 ways in which you can prescribe low vision telescopes. The first is to use the thumb rule, which is that if the vision is greater than 660, you straight away give a 2.5x magnification telescope, and if the vision is less than 660, you prescribe him 6x or 8x telescope. So this is the easiest thing to do, and as Vivek has already mentioned, a 8x telescope is one of the most useful telescopes, and if you have just one telescope in your clinic, keep an 8x telescope. It is useful for all patients. It will improve their vision and give the wow effect. He'll be able to read down the chart and he'll be very happy. The second way to do it is to first predict what kind of magnification the patient will require and then prescribe a telescope. So here you have to first set a target acuity. You have to ask the patient that what kind of vision do you want? So patient says, oh, I want 6 by 6 vision, or he says, oh, I'll be happy with 618. Or if he doesn't know, if he doesn't have any idea of what kind of improvement he requires, you take a ballpark figure of 6/12 Snellen equity. And then apply this formula over there that the magnification you require is equal to the desired vision divided by the current visual acuity of the patient. So as you can see in this example, if you want to improve the vision from 660 to 66, then the magnification required would be 60 divided by 6, which is 10x. So a 10x telescope is what the patient requires. Now once you find out what kind of magnification is required, you give the telescope to the patient, make him sit in your clinic and give him training, which may be for half an hour, maybe 1 hour. You make him sit in the clinic, put the telescope over his eye, look around, identify objects, look at signs. And then what I usually do is I have my assistant or my ophthalmic assistant or a class 4 staff take the patient out on the streets and make him use the telescope on the streets. And if he is comfortable in both indoor and outdoor use of the telescope, then we finally prescribe the telescope to him. Now the second thing is near low vision devices. How do you predict what kind of magnifier or magnification device a patient requires? And for that, Kestenbaum has given a very simple rule that you take the reciprocal of the distant visual acuity if you want the patient to read newsprint. So if he wants to read Times of India or Indian Express, then if his vision is 6 by 60, then you take the reciprocal of that, which is 10, or 10 diopter sphere is what he requires, which is 2.5x if you talk about magnification. Likewise, for N6 vision, you multiply the reciprocal of distant vision by a factor of 1.4, and for N4 vision, multiply it by a factor of 2.8. But remember to deduct the available accommodation as per the line given at the bottom, which is for ages 10, 20, 30, 40 and 50 years. You have to deduct 8, 6, 5, 3 and 1 diopter from the calculated value. But remember, Kestenbaum's rule doesn't apply for all patients. Some patients who've got a central scotoma will require twice the amount of dioptric power that you have calculated by this rule. So this is a rough idea. You have to play with the magnification. Whatever magnification you have predicted, you can go 1 or 2 steps above or even below, depending upon the comfort level and the desire of the patient. So these are the steps when you're prescribing near LVA. First thing is to try a spectacle magnifier. Okay, predict their magnification, give him spectacle magnifier. As Vivek has already told you, it is most unobtrusive. People love them. It doesn't advertise their defect or disability. It can be given binocularly also. The second choice would be a hand magnifier. A stand magnifier is given only in those patients who've got a tremor or arthritis and prolonged near tasks have to be done. Tele microscopes, which Vivek did not discuss and which are very expensive, normally we don't give it in our practice, are for those patients who require a large working distance for near. Then you shift the patient to reading large print books. When he is not able to read text lower than 18 point, even with high ads, and you prescribe a CCTV when 18 point text is not visible with high ads of plus 32 diopters. And if all this fails, then you ask the patient to shift to reading and writing Braille. So this is something which tells you how much they cost. About spectacle magnifier would cost about 500 rupees, a hand magnifier 250 rupees. Telescopes are very, very expensive, and these are old figures. The last telescope I prescribed was about a year ago, which I had to import from Norway, and at that cost about 16,000 rupees to the patient. So it's the cost has increased and doubled in recent years. So in India, where do you get them from? And these are some of the places where you can buy them from. Baliwala and Homi in Mumbai, and the pictures on the left are from Baliwala testing kit, and this is a very simple kit. One can buy it locally, and then you can get some good low vision devices from Madhu instruments in Delhi, Akriti Oculoplastics in Hyderabad, and Lensal Optics in Pune. But this is not all about treatment of low vision. You see, if a person has got multiple handicaps or has got profound visual loss, then a lot of other disciplines come into play, and one has to interact with other medical professionals and social workers and special teachers and occupational therapists to treat such patients. And if you're not able to do it, the best thing is to refer to a specialist if you have one in your town. Then environmental adaptation is also very important for low vision patients. As you can see, a tactile floor over there. If you go to foreign countries like Japan, for instance, or in certain European countries, even the pavements or the sidewalks in the streets have got this type of tactile tiles to guide low vision patients. Now on the right hand side, you see the new wing in my hospital being constructed. This was several years ago. And I told the architect to put contrast lines, as you can see over there, the dark brown lines, so that low vision patients can easily follow and go along the corridors wherever they want to go. And it's easy for them to identify and navigate themselves in the hospital building. So this brings us to the end of this session, not